So now we will move on to our second session, which focus on clinical oncology area with the title Interstitial Brachytherapy in Gynecologic Tumor, where indeed every millimeter truly matters. So it is my pleasure to introduce our speaker for this session, Dr. Rangasamy, Ramachandran. So Dr. Rangasamy previously working in Hospital Sultan Ismail in Johor Bahru before joining our department last year. And Dr. Rangasamy has undergone extensive training at several cancer institutions and is being actively involved in multiple clinical trials, so serving as both principal investigator and also sub-investigator. And his clinical interest is brachytherapy, which is the topic for today, as well as the breast, head and neck, and also gastrointestinal malignancies. So without further ado, I would like to invite Dr. Rangasamy to deliver his talk.
Right. Thank you so much, Ika, for the kind introduction. Let me share my slides. Okay, can you guys see my slides?
Great. Yes.
All right. Thank you. Okay, I'd like to thank University Malaya for giving me this platform to talk about something which is very close to my heart: interstitial brachytherapy in gynecologic malignancy, millimeters that matters. All right. Okay. So this is my disclosure. I'd like to thank Prof. Umesh. He's my mentor from Aroy Gynae. He has shared some slides, courtesy from his slides as well. Right. So let me explain to you what is brachytherapy. Right. So brachytherapy is a form of radiation therapy where a sealed radiation source is placed inside and next to the area requiring treatment or next to the tumor. So brachy means in the Greek form, Greek word is called short distance or short. So therapy is treatment. So basically, you are putting a sealed radiation source next to the tumor to treat the tumor. That's why it's called short distance radiotherapy, or sometimes people call it internal radiotherapy. We call it as brachytherapy. Right. So what are the types of brachytherapy that we know? So number one is intracavitary, where the applicator is placed within a natural cavity. So example is the applicator, which is intracavitary applicator. We will put it inside the uterus and to treat the cervical cancer. This is an example of a case that intracavitary. So how about interstitial? So needles and catheter seeds placed directly into the tissue. This is an example from the breast cancer. So where you put a lot of needles and catheter and inside the tumor and kill the cancer cells. So another example is prostate cancer, where you put a lot of needles inside and treat. So it's a part of interstitial as well. How about surface? So is the applicator apply externally to the skin or tissue surfaces. So we put in the applicator on top of the surface of the skin of the body contour to treat the cancer cells. So the example is actually skin cancer most of the time. How about intraluminal? I think you can get it from the terms called luminal. So its tubes is placed inside the tubular organs such as bronchus and arteries to treat the cancer cells. And sometimes in the trachea, we put inside, the applicator was placed inside the lumen of the trachea and treat the cancer cells there. All right. So I think I am closely work with the gynecology team, and my forte is about gynae, and I love treating gynae cancer. So so brachytherapy is always associated with cervical cancer. So cervical cancer is the fourth most common cancer in women worldwide and strongly associated with the persistent HPV infection. So the main treatment, the mainstay of the treatment is CCRT. CCRT stands for concurrent chemoradiotherapy together with the brachytherapy. So brachytherapy is cardinal. I always tell my trainees and everybody, no brachytherapy, no cure for cervical cancer. So brachytherapy is very, very important element that need to be incorporated into radio treatment of cervical cancer. If you don't do brachytherapy, there's no cure for your patients. Right. Let's talk about some little bit of epidemiology and incidence. So cervical cancer incidence mortality based on the WHO 2020. So we have 600,000 cases annually, and unfortunately there are 340,000 deaths annually. But if you can see here, so 90% of the burden falls entirely outside the Europe. and North America. So the incidence is drastically higher in low and middle income countries, especially in Asian countries, Southeast Asia, and also Malaysia is one of it. Right. So let's talk about the treatment of cervical cancer. So I divided into two. Number one is external beam radiotherapy delivery using LINAC. That means the radiation is delivered externally. Another one is brachytherapy delivery using afterloader. So we have to do one by one first. The first one is external beam radiotherapy, where the radiation given externally and followed by brachytherapy when there's internal radiotherapy. If you can recall, brachytherapy is short distance radiotherapy, where you put the applicator near to the tumor to kill the cancer cells. That's why it's called brachytherapy. And this delivery using the afterload. So if you combine both, then you can cure the patients. So if you do only external beam radiotherapy alone without brachytherapy, there's no chance you can cure the patient. Right. So why brachytherapy? Why brachytherapy is very beautiful, and I would say something is very beautiful and something that I always passionate about. Why? Because the beauty of the dose distribution that it can produce. Right. So example, I give you a comparison of these two phenomena. The first one on the left side that you can see is actually EBRT. When you see the EBRT, then I hope you can see my cursor. So 50%, so in EBRT, they will give high dose radiation to the tumor. At the same time, there's a lot of dose flash to the OAR nearby. OAR stands for organ at risk, bladder and rectum. You see here, almost entire bladder is in the treatment field, and so almost everything is getting 50% dose. Where you can see here in a brachytherapy, so once you put the applicator in, so the yellow line is the tumor, where you can see the tumor is receiving almost 200%. So the red dot line here is the 200% isodose. And you can see the bladder and the rectum is very near to each other. But you see how beautifully it drops. The dose drops. The dose fall off is very good in brachytherapy. And you can see most of the bladder is only giving 50%. So this beauty is only can be seen in brachytherapy compared to EBRT. So if you want to boost the tumor, the only way of boosting the tumor in cervical cancer is with brachytherapy. Right. So then the organ sparing is remarkable in bladder and for brachytherapy for bladder and rectum compared to EBRT. And this is actually basically because of the type of energy we use. You use 6 MV photon, the fall off is not that great, but when you have a gamma, which is emitted by this brachytherapy sources, then the dose fall off is remarkable, and it follows the inverse square law of 1D/Q3, right? So now next is, what is the volume changes during treatment? I think that is very important. So when you have a cervical cancer patient, and when you're giving an EBRT, you're expecting 75% of tumor regression. The balance 10%. How are you going to take the 10%? Is the only way is by doing brachytherapy. So what we do normally in our center, wherever center you're practicing, you are coming from, the cervical cancer treatment standard treatment is intracavitary applicator. Let me explain to you. So this is the toy that we have in our department that we always play around with, and I love this. So this is called intracavitary applicator. So the middle one is tandem intrauterine tube. Flange is the place where you put it at the external os, and at the forniches there you got this ovoid and you lock it, right? So let me explain to you how is it done. So we have the intracavitary applicator, and this is, we have flange, we have a intrauterine tube, an ovoid, and there's a lock and there's a flange there. So basically when we put it inside the uterus, and you can see here the tandem is inside the uterine canal, the ovoids at the level of the fornication, and you lock it here. So what happened is, so once patient has done the applicator insertion and the transfer to patients to the CT simulation area. So we scan the patient. After that, we delineate the tumor, the HRCTV, the high-risk CTV volume. Then after that, the physicist will reconstruct the applicator, and then the sources will emit gamma rays. And this is the gamma rays, the isodose that we want the 100% cover the tumor. So this is the basic principle what we do in daily practice to address the cervical cancer post EBRT with brachytherapy, which intracavitary applicator, or simply called as IC. Right. So let me bring you back a few years back, I think 10 years or 10 years back, with a traditional brachytherapy, how things are done long time ago. So the last time, when it comes to brachytherapy, it's an X-ray based situation and it's a point based situation. You prescribe to point A, right? So so if you this is X-ray, and I'm sure all of you know about this X-ray thing. So what happened is we put the applicator, we bring our radiographer inside the OT and ask them to do II images, right? So once they've done the II images, if once we see the applicators is inside to inside line, so we will figure out where is the flange, right? So once you got the flange, we determine the flange. After that, we put 2 centimeter superior and 2 centimeter lateral, and that is your point A. Right? So after the point A is determined, the physicist will prescribe to the point A, and you sort of supposed to get a pear shape, right? Pear shape isodose line, and we determine where is your rectal point. How do you determine the rectal point? By the packing. So this is the packing of the vaginal wall, and posterior 5 mm behind the posterior vaginal wall. Then this is your rectal point and your bladder. So what happened is during the procedure, we put a contrast in the balloon of the bladder, and the center of the Foley balloon is where your bladder point is. So once we have determined that, and then we report what is the prescriptions of a point A and how much the patients received, what is the prescription to the rectal point and the bladder point, then we treat based on that. But this point A prescription, there's some limitation. What are the limitations? So you see a point A is defined relative to the applicator, the tandem and avert. In a good days, tandem straight. Sometimes the bad days, tandem might not be straight. And the anatomy might be different from one patient to another. So will we be able to rely on this point A forever? That's the question mark. How about placement sensitivity? So you see, as I told you earlier, the position of point A shifts entirely based on the how the applicator is situated within the patient. So there are moments that the applicator is not in the right place, it's not straight, then your point A might be different from one patient to another. How about volume neglect? So when you're giving EBRT volume, and then EBRT, the volume of the mass differs from one session to another. I mean, in terms of the brachytherapy session, right? So there is the regression of the tumor. So it doesn't account for any specific size or shape or regression of the tumor during treatment, and it can underdose the big tumors, right? I'm sure from X-rays, you won't be able to see where is the tumor. You really cannot see where is the rectum and bladder. So that is the limitation that we have. So this is the example of a cartoon picture that I got it from online, and you can see here the red is tumor, right? So this blue is your OAR, right? And this when the moment the tumor is small and you prescribe to point A based on 2 centimeters superior and lateral, and you're very happy, you cover. But remember, you are overdosing, or you are actually delivering high dose to the tumor, but exceeding the OAR limit. The OAR is very near to each other, right? I give you a second scenario when the tumor is damn huge, right? It's big. When you're giving this 2D planning, and then you prescribe to point A, and you see this part of area is not being treated. When you do a standard pear shape, this is not being treated. So 2D planning grossly underdosed the tumor. So these are the challenges that we had 10 years ago when you use traditional way of treating brachytherapy with X-ray. Right, so the evolution takes place, right? So initially we go for X-ray, and the evolution of brachytherapy, we come with a brilliant idea, I would say. We say, why don't we have a CT simulation? Why don't we use the CT and delineate the tumor and come out with a proper target delineation? So this is called image-guided brachytherapy. Image here simply is because the CT or MRI, whatever modality that you have in your center, then after that it's a 3D-based situation. Why 3D-based? You can see, really can see the tumor, and you can see where is your OAR. You can delineate them, easy for the physicist to see where is the target, and they can optimize it based on that. So this is how beautiful it is. And then we decide on, okay, now we got a volume base. So I think we should report based on the volume. So that's why we have a T2CC for rectum, bladder, and bowel, and we got HRCTV, high risk CTV. We know where is the tumor, the entire cervix, where is it? Then we delineate based on that, and we report based on that. All right, so let's bring you back again to the X-ray based situation. So now the question is, okay, now you have converted from X-ray to 3D, right? So from 2D to 3D era. So is there any evidence to say 3D is better than 2D? Right, we have that. So best historical results that you can see the local control. If you see, this is the X-ray based situation. Right, so we have a 1B, 2A, 2B, and 3B, and 4A diseases of cervical cancer. So when you do an X-ray based situation, you see not bad. So you see 1B diseases got 90% local control, when 2B diseases got 78%. But I want your attention here. I want to have a concentration here. When it comes to 3B and 4A, the local control is not that great, right? Especially 4A diseases. What is 4A diseases? The tumor involving the rectum and the bladder, right? So this is the conventional brachytherapy compared with IGBT. So if you can see here, the disease-free survival is almost the best. Of course, the tumor is small, and then you can do a pear shape and prescribe to point A, then you can have good control. But when the tumor is big, the disease-free survival is not that great. You can see the graph is separating. When it comes to 4A, 4B, there's a remarkable distance from 1A to 3B are grouped together. The 4A, 4B is standing alone. So that means the disease-free survival is not that great for 4A, 4B when you do a conventional brachytherapy. But if you see in IGBT, the FIGO stage has lost the prognostic significance, where you see the entire graph is shifted up, and the local control is almost 90%, and the FIGO stage has lost. So with almost every tumor, which but doesn't matter, it's a 1A diseases or 4B diseases, gets a very good dose, and the local control is 90%. This is remarkable, and this is a landmark trial, and this is why we have shifted from 2D through 3D. Right. So I'm talking about brachytherapy. So I want to know, I want to tell you guys like how things are done in my center. Right. So for the first time when the patients come to clinic, diagnosis of cervical cancer, FIGO staging is very important. I always train my trainees that FIGO staging is the must, and then if they don't know, they will get some penalty from me, right? So FIGO staging and clinical examination and mapping of the disease is important. What is mapping of the disease? We have this clinical drawing. So the moment I joined then I make sure this is printed out and put into my clinic, and clinical drawing is very important. I'm guiding my trainees to tell them how to draw the tumor, and clinical examination is your vaginal examination is important, and you plan for EBRT. So the clinical drawing, we have two. One is pre-EBRT. So whatever whatever disease is there from the vaginal examinations, you need to be illustrated in the clinical drawing. So this is an example. I just run too slowly. Quickly here. This is your cervix, and this is your fornications. This is your vagina, right? So, so this area is your bladder, and this is your rectum. This is your parametrium, right? And this is your vagina divided into upper, mid, and lower third of vagina. And this is your parametrium. And this, for these patients, the tumor is involving the entire cervix and the fornications, and also involving the almost upper third of the vagina involvement. And then you see the parametrium, medial parametrium is involved as well, right? So what is next, right? Of course, if you get an MRI pre-EBRT, there's an ideal situation. We know there's some limitation to get an MRI, and we are in a situation where we need to treat the cervical cancer as soon as possible. But don't worry, if the limited resources situation, whatever we have, your vaginal examinations and your clinical drawing and the CT scan that you have is sufficient to start the treatment first, right? So now after that, we do a EBRT, external beam radiotherapy. And once they're done external beam radiotherapy, second time, you need to draw the clinical drawing again. So what is it done? This is actually post EBRT. And then this time around, normally, we will get help from our radiologist, kind radiologist, to get an MRI for our patients. After that, from the finding from the MRI, also we delineate the tumor or map the disease again. So now you can see the difference. Now the tumor is confined to the cervix. There's a little bit of foreign involvement, and the parametrium involvement is actually effaced. And if you can see here, the vaginal involvement is more on the pre-EBRT. Now is almost nothing there in the vagina. So this is at brachy. So this is how we do the clinical drawing before starting the brachytherapy. All right. So once done, right? Once done, so this is we have the clinical drawing. We will also, we are very grateful that we get an MRI from a radiologist, and then we will measure the diseases and see how extensive it is. Why is this important? So always tell my trainees, I think it's important to have a pre-brachy assessment. So selection applicator is important. Why is it important? It's like how the surgeon before going into the surgery and then the operation theater. I think as an oncologist, we need to know about we need to have this pre-brachy assessment where to decide on the selection of applicator and topography of the disease anatomy, right? So if the selection of applicator, what kind of applicator you are going to use? So is it intracavitary sufficient for this kind of case? Is interstitial needed? So I tell you that this is intracavitary. I explained to you earlier. Interstitial is the MAC applicator. This is from the BBIG. These are the needles we normally use. This is one of the Porsche that we have. Right. So once we have decided on the selection applicator based on the topography of the disease and anatomy, then we go into the OT and we put the applicator in. Right. So once the applicator is inserted, then we bring the patient to the CT simulation area. These are our radiographers, and they will do the CT scan. Then we acquire the images, and we make sure the applicators are inside to number one, and number two is aligned. Right, and you need to make sure also how much the bladder capacity is needed. So let me tell you about the bladder capacity and why is this important. So normally certain different center practicing different way. The volume of the bladder we want to give 30 cc of normal saline is basically some 29 cc of normal saline with 1 cc contrast. Why we need to put a contrast in the bladder? Because to delineate the bladder, and then you need to delineate the bladder volume. Right. So because remember, if this is a 3D based situation, so with a volume based situations, I think you need to know how much bladder is the 2 cc of the bladder is received. So in order to that, you need to delineate the OAR, which is bladder. So some center we go for 50 cc, and some centers 20. So it's variable. It depends on each center and depends on the daily practice and your local protocol, right? Sometimes what happens is when the lot of bowels are dropping, I try to increase the volume of the bladder simply to push the bowel away up so that I can so that the bowels are not getting, because the bowels are sensitive, we only allow less than 5 gray per fraction, so we don't want the bladder, I mean the bowels get a high dose, so that's why we push the bowel up through this one by increasing the capacity of the bladder. So once this image is acquired, so what we do next, we delineate the tumor, right? And then after that, we call it this HRCTV, and we find out where is the OARs, and then we delineate the OAR as well. So the next step is important. Yeah, these people are the heroes behind the screen, and we have a physicist here. So this physicist is actually try to reconstruct the applicator, and then they prescribe and they optimize. The optimize meaning they want to give a very good dose to the target, at the same time reduce the dose to the OAR. They optimize it by playing around the dwell time and position. So once it's done, we approve, we're happy with the plan, then we deliver the treatment. And so this is Saginova, and this is afterloader. And you can see here there's a transfer tube going into the applicator, and this is where your gamma radiation comes in, and radiotherapy is being delivered internally. And the treatment is, after the treatment, what you do next is remove the applicator. Right. So this is our planning aid. So when once the applicator is in, then the reconstruct the applicator is in, then we do the CT simulations, and you're happy with the images, you're happy with the contouring, and then you're happy with the plan. And what is next? How you make yourself happy with the plan is actually by looking at the target aim that we want to achieve. So this is for adapted from Embrace protocol. There's a lot of parameters you need to look at: D98, T90 and HRCTV, 2 cc of rectum and bladder and bowel and sigmoid. So this is you can get it from the EMBRACE protocol. And what we want to achieve is the total EQD. Total EQD, the total dose that we want to get is the contribution to EBRT in brachytherapy. We want the target to reach more than 85 gray, right? For each fraction, right? So the more than 85 K is accumulation of few fractions. Normally we go for 4 fractions and total dose we want to get is more than 85 K. But for when it comes to each fraction, we want the HRCTV to get more than 7 Gray and the 2 cc of the rectum, 2 cc of bladder and 2 cc bowel. We want the 2 cc of rectum get less than 5 Gray and the bladder, the tolerance is a little high, so you can go for less than 6 Gray. But bowel is same as rectum, we want the less than 5 Gray. Right. So this is an ideal situation, right? So when you have a tumor, it's only 10% left behind, and you want to put the applicator, you have an intracavitary applicator, you put the tandem, you put the ovoid, and then you lock it, and then you reconstruct, you plan, you're happy, you approve, and then you make sure the target is aim is achieved and all that, and you're happy, you go back and sleep well. But this is not the case every time, right? So it's in daily practice, we have more challenges, right? Are we able to achieve the planning aim in our daily practice? The answer is no, right? So why no? Let me explain to you in detail, right? So when you have a patient who had EBRT, you need to categorize them into 3 categories. So one is brachytherapy category 1, where there's no residual disease. The tumor is only confined to the cervix, right? So if category 2, the tumor is actually, there's a lateral extension and is going into the medial half parametrium, right? So if category 3, then the tumor is going beyond the medial parametrium and going into lateral side walls. So these are the important one. Type 1, category 1 is confined to the cervix. Category 2, medial parametrium involvement, and the category 3 is lateral parametrium involvement. This is the common topographic of the tumor every cervical cancer patient who has completed the EBRT, and you can see the lateral extension that matters. Why? All right, let's see this. Right. Okay. So this is actually a tumor, right? And this is tumor, and the tumor is confined to the is only confined to the cervix, and you see the 100% isodose. This is category 1. So most of the patient falls into this category, and if you do a standard applicator with IC, intracavitary applicator, and is limited to cervix, minimal parameter involved, intracavitary is sufficient, and you are able to achieve a planning aim with a tandem or ovoid, and you're very happy. You can see this is the 100% isodose line, and the tumor is somewhere around here, and you're happy about it, right? Correct? So this intracavitary is sufficient for category 1. But let's see next case. So when there's a category 2, when the residual is cervix and the tumor has gone into beyond the parametrium and is gone into the parametrium, and medial half parametrium is involvement, and you can see the 100% isodose is not covering the tumor. So are you happy? I'm not happy, right? So this is something that is really worrying because we are not hitting the target here. So what we're going to do next? So intracavitary is insufficient in this situation. We are missing the target. Can you achieve the planning aim? Remember the EMBRACE protocol where you can see EMBRACE guidelines of planning aims that we're supposed to achieve. I don't think so. With this, you can get an HRCTV more than 7 gray, right? If you delineate the tumor well and all that, so 100% dose is not covering. So what we're going to do with this? So in this situation, intracavitary, IC, IS, interstitial needles important is called as tandem. It's called as hybrid situation where you have a tandem and ovoid and you put a freehand needles there. So this is an example of case. So you can see here, I'm sure you're familiar with this. This is intracavitary applicator. What we did, we see, remember the lateral the parametrium is involved laterally, the medial parametrium is involved, and we put the needles here, right? And then with the ultrasound guided, and so this is the needle and this is the outcome. So you can see the tumor is delineated in the dotted line here, and you can see that the isodose line is able to cover, and is because of this needle the dose bulges out. If imagine there is no needles here, the dose will be somewhere around this region, right? And we're missing the parametrium, region where the tumor is. Right? Clear? Right. So this is how you see the needles. In this is the interstitial needle. Right. I'll bring you to the category 3. So where you see the significant residual disease extending to distal parameter. This is more severe to brachytherapy category 1 and 2, where you see the tumor is the isodose 100% is only covering less than 1/3 of the tumor. Yeah, so most of the tumor is away from the isodose and you are not covering, and this is something really worrying. So intracavitary is insufficient. We are surely missing the target here. We are confirmed we are unable to achieve the planning aim. So what we're going to do, we give IC plus IS and sometimes IS, interstitial alone. So we had a MAC applicator, we put the applicator in, we target, and then you see the target is here and able to cover with the interstitial. So this case, intracavitary alone is not sufficient. You need to add some interstitial needle. And if you have an interstitial like a template like this, then purely perineal plate, then this will be very helpful to cover. Right, okay. So in summary, then post-EBRT, you need to assess the patient, whether it falls in the category 1 or category 2 or category 3. So based on that, you decide whether you want interstitial alone, intracavitary alone is sufficient, or you want to do a hybrid session, intracavitary plus interstitial, or do you want to do a purely interstitial? So summary, category 1, you go IC alone is sufficient. Category 2, when you have IC plus IS is sufficient. And then category 3, you want to do a hybrid or interstitial purely. All right. So do we have evidence to support this? Okay, we're putting interstitial needles. So how's the local control and all that? I understand your concern, and I think there is the answer in the retro-embrace study by Lord Fogdall. So they have found out when you see the IC plus IS, when the CTV-HR is more than 30 centimeter cube, so you can see that local control is much better. So I want to get your attention here. When less than 30%, okay, the moment you draw the HRCTV, if the tumor is small, it's less than 30 centimeter. If tumor is big, is growing big laterally and more than 30 centimeter cube, and then you will need to alert yourself. So probably this is not sufficient with the IC alone. You need to give extra needle there to cover that area, then you can achieve a local control. Right. So indication for combined intracavitary interstitial. So when you're supposed to combine interstitial needle with intracavitary, when you have a distal parameter to extend, I explained to you with the graphic just now, and when you have unfavorable topography, unfavorable relation to the applicator, when you sometimes you get an asymmetric tumor. I will give you an example later. And distal intravaginal tumor growth. Remember, the standard intracavitary is not be able to cover the distal intravaginal tumor, and if you have a paravaginal tumor growth, I'm sure my trainees will know about paravaginal tumor growth because we have done one case. I'll show you later, and we have put needles there, and standard applicator will never be able to tackle the situation. And there are moments that challenges comes in life, and there are moments that unfavorable topography or organ risk is there. So I'll give you an example later. All right, so let's talk about the real world case that we have encountered, we have tackled it. Right, so this is the first case when a 51-year lady with a cervical SCC FIGO3CV1 because she's got a lymph node positive. This is at the diagnosis. You can see the tumor is confined, is at the level of the cervix and the fornicaceous involvement, and then you see vaginal involvement as well. And here you can see almost no vaginal involvement. Tumor is confined to the cervix, but you see the parametrium still there. Right, so we have done a discussion with our radiologist, and then we found out this is a brachytherapy category 2 is because the medial parametrium is involved. Right, okay, then what is next? So what we did, we put an extra needle here, and then we know intracavitary alone is insufficient in this case. So you see 1 needle, 2, 3, 4, because it's a lateral extension. We put the needles here, and then you see the dose just nicely covering the target. So this will not be achieved if you imagine only the what you call the tandem is alone here. Intracavitary alone, it will not be able to achieve this. Will not be achieve a good dose to the target. Right. So what happened is we first fraction intracavitary interstitial. Remember, we want the HRCT more than 7 gray, we able to achieve, and then the bladder we want the less than 6 gray, able to achieve. Rectum, we want the less than 5 gray, we're able to achieve, and the sigmoid bowel, everything is less than 5 gray, and we're happy. So we've continued that. first, second, third, and fourth. And total, remember, we want more than 85 degree total, and we want the bladder and rectum, sigmoid, bowel, everything has to be less than, the bladder has to be less than 85 degree, we'll be able to achieve, and then rectum, sigmoid, bowel, we want the less than 75 degree, be able to achieve beautifully with this interstitial and intracavitary. So this is the example of, this is the MRI, we got it pre-brachytherapy, and this is after 6 months of treatment, and you can see there's a complete response. Right, so category 3 is until lateral parametrium involvement, and you know intracavitary is not sufficient. In this situation, you need to add some interstitial needles here. So we have this MAC applicator, we put the needles in, and you can see we use the MAC applicator here, and you see the HRCT, how beautiful it is, more than 7 gray, and the bladder initially 6 is on the borderline, then after that it has gone to 5.5, 5.9. End of the day, we were able to achieve less than 85 gray. And the rectum, sigmoid, bowel, total PQD2 is less than 75 gray. And we are happy we are able to sleep well. Right. So I think I told you regarding this asymmetric tumor. So sometimes a tumor can be very tricky. Right. So if you can see here, this is a case we thought is intracavitary. Sorry, we thought it's a brachytherapy 1. So brachytherapy 1 means the tumor is confined to the cervix, maybe the parametrium effaced. So we thought, okay, why don't we try intracavitary alone, right? Applicator. So we tried the intracavitary alone, but after this images, then we found out the tumor is bulging posteriorly more compared to anteriorly. If you can see here. Right? So the 100% isodose line, which is red, is not covering the tumor, you're missing the target. So we started with intracavitary, then you get the best you can get is 6 gray out of 7, and the bladder is the rectum is 6 gray. And then for some reasons, the patients went for this next step, the same step again, and you see, of course, you get a 7 gray for HRCTV, but the bladder is, we call it is burning. So the dose is higher than expected. So it's supposed to be less than 6 gray by 6.4 gray. So what happened next is the third fraction and fourth fraction is crucial now, because we want to achieve the target, right? We want more than 85 gray. At the same time, we want to save our OAR. So what we did a MAC applicator in the third and the fourth, and you can see how beautifully the dose, what we call target is achieving more than 7 gray. And then the bladder dose drop from 6.4, 5.1, and 5. And the end of the day, we're able to achieve the target, achieve our planning aim. So with the target getting 85 gray, then the bladder, rectum, sigmoid, everything is within the dose tolerance. So what I'm trying to say here, when you fail at the first attempt, don't give up, right? So second attempt, you fail, don't give up. The third and fourth, you need to plan which applicator is important, which applicator, because sometimes the technique might be wrong. So when you route the right applicator at the right time, and you can see a beautiful results. Right, so unfavorable OAR, even though it's a brachytherapy category 1, then you can see that the OARs love to sit around uterus. So you can see the bowels are dropping, the bladders are bladder is very nearby, and the rectum also reasonably is very near, especially this bowel will be a problem. Remember, bowel, the tolerance is low, less than 5 gray. When you do an intracavitary applicator, HRCTV, the best it can be 6.3 out of 7. The bladder is 5.8, but you see the bowel is the problem now when you get a 5.2. So the next insertion, we plan again. So if you do this intracavitary alone, next time, I'm sure you're not going to achieve what you have to achieve in the planning aim. So we change the type of applicator. We use MAC applicator here, and you see the dose to the target has gone up to 7.5, and the bowel has dropped to 4.0. Right. So this is when you're doing more and more what we call the applicator insertions, and you more brachytherapy. There are a lot of things that you need to learn, and there are a lot of things that you don't know that you don't know. Right. So his example is, this is actually a recurrent endometrial cancer. This is a post-TAPSO patient where this is a lesion here at the wall recurrence. So this is a very interesting case where when you put a standard applicator, right, is normally what we do post-TAPSO is DOBIS. So everybody knows about it, right? So when you do a normal DOBIS, I mean vaginal brachytherapy, you won't be able to get a good dose, right? Because the cranial caudal extension is around 3 centimeter, but the applicator you use is only be able to cover with 0.5 centimeter. Everybody do brachytherapy and they know about it. So this is the challenge. So you certainly won't be able to cover the target. So this applicator is not the ideal applicator that you can use. So what we did, we get this MAC applicator, we put the interstitial needles inside the applicator. Then after that, you can see how beautiful it is. Then we able to, this is the tumor, and we able to cover the tumor with 100% isodose simply because you choose the correct applicator. All right. Okay, so the tumor received total liquidity of 86K in this case. All right. Okay, so this is more challenging case, right? You can see there's a gross disease. Okay, this is a recurrent endometrial cancer. If you ask me, recurrent endometrial is very tricky and very challenging. So because the moment they recur at the weird place, and then it's uncommon area. So this is very near to the rectum. If you can see, this is the tumor, is a pararectal mass. So what we do, we have a challenge here. So we're not sure how is a standard applicator alone. I mean, what we do, we have a MAC applicator, but we put the needles here, we're able to cover. But it's very near to the rectum, and there is a pararectal regions involved. So what we have to do is we put the needles beyond the applicator to cover the area. So the tumor is around lateral and going posterior, right? Something like this. So you see our needles also going lateral and going into the posterior, sorry, right? So we put extra needles here. We measure with the MRI, so how much needles need to put in, and then how deep we need to put in, and we work based on that. And thank God we able to hit the target. You see the needles here, so we able to cover the target. And these patients, PET scan pre-op, this hypometabolic hypometabolic activities there. Then after the PET scan, post EBRT, and also the brachytherapy, she has a complete response in the metabolic region. Right. So this is a case that I think my Chinese knows well. Okay, this is a region where the paravagina. Remember the indication to do intracavitary and interstitial needles in the paravaginal disease. So this is a vaginal cancer patient who had an EBRT, and she has a residual disease of paravagina. So what we did, we put the needles at the paravaginal region with the ultrasound guided, and we are very grateful. We have a Gynecology team who come and help us to do the ultrasound and put the needles, and you can see be able to cover the target well. Right.
Dr.
So in summary,
Dr. Ranga, so I'm sorry to interfere, but due to time constraint, can you?
Okay, so this is my last slide.
Okay, thank you.
So we choose appropriate techniques depends on the residual tumor to put away brachytherapy, then availability of brachytherapy applicator, and availability of expertise that you have. So go back and check again what are the applicator that you have in your center. Based on that, you decide. If it is confined to cervix, IC alone. If it is extend beyond the cervix, IC plus IS combination. In essence, this is not amenable for IC, IS, probably you get interstitial. Right? So application can be modified from one fraction to another. So brachytherapy skill is work hard to strengthen your skill, like laparoscopic and robotic surgeons, like house surgeons, they train themselves. You need to train yourself for the brachytherapy skills as well. So first time, it's not perfect, but practice make perfect. And remember, Rome was not built in a day, so it takes some time to get to know about the disease and get to know about brachytherapy works, and you can improve your expertise. So I'm grateful to have a brachytherapy team UMC, and we have a lot of heroes behind the screen, and we have physicists and radiographers and my trainees, and we have a radiologist who will come and help us get an MRI, and gynecology for ultrasound and referral cases, anesthesia for the spinal. All right, thank you.
Thank you so much, Dr. Ranga. So I think we have one question from Professor Emeritus Prof. Ng Kwan Hong. Brachytherapy has come a long way since the era of radium seed, and where are we heading in the future, and how effective is this improved technique for non-gynae tumor?
All right. So now in UMMC, that what we do is actually we are focusing on the gynae tumor sites, right? Non-gynae we have not explored, but I think our friend in USM, Dr. Kogula, has explored it regarding this non-gynae tumor site, especially head and neck. And we have done some for keloid, right, Zulaikha? So, and we have found a fantastic, a very good response with the brachytherapy. Because I think the beauty of the brachytherapy is because the dose fall off and you can what we call preserve the OAR compared to other modality that you have. Is I think it's because of the type of energy we use. So if you ask me, in future, there is a future for brachytherapy, and I believe in that. And I think a lot of studies has to be done and a lot of work need to be done for that. And so I think awareness of brachytherapy is important because we can cure a lot of patients. I think there are a lot of studies coming up where when there's a recurrent, then you can give brachytherapy because the dose fall-off is fantastic. And I can see the future. I can promise that. And I believe in whether it's a gynae or non-gynae, tumor size brachytherapy plays an important role.
Okay, thank you. So we would like to thank Dr. Rangasamy once again for his valuable sharing. I think this is the end of our session for today. So thank you to all participants for your active engagement. And so I think I will now hand over back to the organizing team. So thank you all for joining our Breakfast Health talk for today. Thank you so much.
Right. Thank you, everyone.
Okay.